Hello, my name's Jim Huddy. I'm a GP in Perranporth in Cornwall, and I'm also the CCG lead for chronic pain. And today I'm going to give you a talk about chronic pain, the patients they never told you about. Right, we've got some quite chunky learning objectives for today. By the end of this talk, I want you to be able to read the future, start a revolution, improve the lives of millions of people, and also to give the pharmaceutical opioid industry a right good kick in the capsules. Let me tell you a little bit about myself. I'm a GP now, but I used to be a gastroenterology trainee about 10 years ago. I was about a year off being a consultant, and then I changed to general practice, moved to Cornwall, and now I work in the hospital doing endoscopy for a day and a half a week, 2 days as a GP, but that leaves a bit of time to work in the middle, and I work in the chronic pain field with some colleagues from the hospital and elsewhere. Let me guess a little bit about you. I'm guessing that you are, like a lot of your colleague medical students in the country, woefully inadequately trained in pain, and you get something along the lines of 12 hours in 6 years. If we do a quick calculation about that, I'm guessing that you have about 200 working days in your year, 6 years to your course, 6 hours in a day, which is about 7,200 working hours, and 12 hours of that might be taught in pain. So that's 1/600th, or 0.16% of your pay, of your studying is in this very important subject, which incidentally is less than a vet. Let's have a little look at the burden of chronic pain in the real world. This is an Australian slide, but the data is very similar in England. 1 in 5 patients will be affected by chronic pain. So in England, that's 13 million people, and 7% are disabled in severity. So that's 500,000, and it gets more common as you get older. About 1 in 5 GP consultations involve chronic pain, but it's not just GPs who are at the front line. The cost to the economy is huge, in the billions, and there's an estimate that this could be reduced by half with decent treatment. And also chronic pain is highly represented in cases of depression and suicide. Let's read your future. There's such an imbalance with between the amount of pain in your working lives in the future compared to your studying lives. So let's say 20% of GP consultations, but 0.16 is in your studies, which is a factor of 125 to 1. It's not 2 to 1 or 3 to 1. 125 to 1. And similarly, let's have a little look at diagnosing cancer. 1 in 500 GP consultations are a new cancer diagnosis. And have a little think about the difference in time that you spend learning about diagnosing cancer versus pain. The disparity is also about 100 to 1. Now, don't think that if you go into specialist medicine that you'll be safe from this type of conundrum. About 1/3 to 1/2 of gastroenterology patients are medically unexplained. All of their tests come out normal, and yet they've got these significant, sometimes disabling abdominal symptoms. And similarly, neurology outpatients, about 1/3 of them are medically unexplained. Look, I don't want to get you down, and I don't want to worry you. Learning about biomedicine is very important to being a doctor. You do need to find the diagnosis and diseases that account for patient symptoms when they exist. But very often in the 21st century, where we are now, you can't find a disease or a diagnosis that causes those feelings that people have. And that part of your training, I believe, is inadequate. Now, you might think to yourself, well, this is years away, I don't need to worry about this now. That's not the case. When you're an F1, you will be called to the ward for people who are in pain, or people who might be in pain, or showing behaviours that could be consistent with pain, and you need to be able to recognise, assess and treat that. What is pain? Well, you all know what pain is, you've all experienced it. If you get booted in the shins, you get these signals going up your leg and your spinal cord to your brain, and you recognise that as a painful stimulus. Pain is a conscious experience. It's a negative sensory and emotional response in your consciousness, in this movie that plays inside our heads. But it's not necessarily just to do with tissue injury. I love this slide. This is from the BMJ a few years ago, and it was a story of a builder who trod on a nail, and the nail went through his boot, into his foot and he was in agony. He got taken to the emergency department. He needed some strong drugs, fentanyl, midazolam I think it was, and the nail was taken out of his boot and the boot was taken off of his foot, and it turned out that the nail had gone between his toes. It hadn't even broken the skin, but he was in agony. He wasn't putting it on, he was genuinely in pain. So what is pain? This slide is in the context of chronic pain, and by chronic pain we mean pain that's going on for 3 months or more, and some of it is because of signals going up the spinal cord, but also there's a lot of signals going down the spinal cord which sometimes are inhibitory and sometimes amplify things. And then of course in our consciousness there are parts that contribute our past and our present and our future and our beliefs about pain and our fears about pain. Where is your attention focused? Mindfulness meditations can affect this. Your mood, whether it's anxiety or depression, or whether you're not sleeping very well, or whether nerves become sensitive, these all contribute to your experience of pain, and also genetics. I recently found out that the genetics of anxiety and the genetics of back pain are very similar, which I think is fascinating. So what happens with chronic pain? Well, you get this spiral of decay, and what happens is that you become less active, you put on weight, your muscles become weaker, you don't sleep so well. Then you can get medications and side effects which can make things worse. You gain weight, you think negatively about the future, you might get depressions and mood swings, time off work and relationship problems. How do we treat it? Well, how should we treat it, more to the point? With this self-care cycle. So to an extent we can help the pain with some physiotherapies or with pills sometimes, but also it's the impact of the pain that we're really trying to help. We're trying to help the disability. Goal setting, self-help options, pacing oneself, getting fitter, eating better, relaxation skills, sleeping better, managing moods, challenging negative beliefs and managing setbacks. These are the things that we can impact on, much more sometimes than the pain itself. But what do we do? Well, you know what we do. We give pills to people, and pills are used much more than they should be. And why is that? Well, you know why that is if you look at your training. How much training do you get on pharmacology and pharmacotherapy as opposed to things like acceptance and commitment-based therapies? Doctors believe that there's a lack of alternatives for treating pain, and it's also much quicker and easier to give someone a prescription. And then they're gone out of your consulting room and you can crack on with the day. If you start getting into a discussion about reducing or maybe stopping doses, that can make patients scared, angry, and we don't want a conflict. So you can understand why we reach for the prescription pad. Also, what about the opioid epidemic? I'm sure you've heard about this in America, which has to be the ugliest story in modern medicine in the last few decades, where the pharmaceutical industry has persuaded us through lies and manipulation of their data to believe that if we give high enough doses to enough people, then we will cure their pain. And in fact, what's happened is that hundreds of thousands of people have died. It's a very, very sad subject indeed. You should read about it. Okay, just one caveat. I'm not saying that painkillers and opioid painkillers don't work in everyone. They do work in some people some of the time, but it is the minority. Right, well, this story in Cornwall made us so angry that we decided to collaborate together. GPs, specialists, pharmacists, physiotherapists, social prescribers have all got together to try and work on this rather gnarly subject. And the Chronic Pain in Cornwall project is helping giving people alternatives to medications and trying to reduce our county's opioid usage. We've got an expert patient called Sean Jennings, who's a real star. He's done a video on NHS England YouTube website, which you can easily find, and he tells his story about how he's reduced his painkillers and he's leading a much more fruitful life now. A lot of our educational resources are on the Cornwall Formulary website, and we can give you the links to those. We've done mainly video productions. The first one was about how to trial and prescribe opioids safely if you're going to, and if they don't work, to stop them promptly. This one's about deprescribing opioids and how to help people come off high doses, and very often their lives can be much better. And this one that we published this year is about what are the alternatives in Cornwall for people, and we believe that this is very helpful teaching aid for prescribers. Okay, so what's happening? Are we succeeding? Well, we think we are. This is the graph of total opioid prescribing for the county over the last 3 years, which is about an 18% reduction, which is pretty good if you look at the rest of England. So we're doing pretty well there. So that's what we've done about it. What are you going to do about it? What are you going to do about this problem in your future that I've now told you about? We know that there's a lot of pain out there. We know that you will have to treat it as a junior doctor, and we know that you're not well trained. If you do it badly, you'll harm people, and also it'll be really stressful for yourselves. Well, let's start a revolution. Oh, no, sorry, not that slide. Let's think of a peaceful way that we can make a protest and try and change things for the future, for the better. I think that there's a cure. I've got a friend and colleague called Helen Makins, who's a pain consultant, and she is the UK lead for the Essential Pain Management course. This is an interesting course. It was developed in Australia, and it was designed for doctors in the third world to help them recognise, assess and treat pain better, because their use of medications was not really helping their population. And it's been rolled out in 55 countries. Helen's in Senegal at the moment, as it happens. And then someone thought, well, hang on, why can't we use this in the UK for undergraduates and postgraduates? And so it's been piloted in quite a few medical schools over the years and had some really great feedback. It's only a half day, and it uses this approach to pain, and I'm going to just increase the size of this slide so I can read it out to you. Recognise, assess and treat. So recognising the individual and cultural influences on pain presentations, the impact of pain on patients, family and society, the benefits of effectively managing it, and a look at the pathophysiology and the psychopathology. Assessing it, the severity, what psychosocial issues might be important, and classifying things into acute or chronic, nociceptive, neuropathic, cancer or non-cancer. Helen tells me that any pain patient can be classified using this fairly simple RAT formula. The T stands for treating, the non-pharmacological treatments, the self-management treatments that I've told you about, and also what medications might help in some situations. Okay, so what can you do about it? Well, when this talk is published, we're going to have a link to a petition that we're going to set up, which will be for Helen to take to the Medical Schools Council and the individual deaneries and to the Royal Colleges, and she will implore to them, with your signatures, the importance of getting pain teaching into the UK medical school curriculum to make your lives, more importantly the lives of our population, better in the future. And if you don't think that that's possible for medical students to make a change, well, I'm sure you know these guys, Bogdan and Daisy Kirtley. They are UEMS postgraduates and graduates, and they have done absolutely amazing at getting the social prescribing forum and movement going within all of UK medical schools. Bogdan's presented at the King's Fund, Daisy's been out to the European Primary Care Conference, and hats off to them, they've done brilliantly. So I'm going to leave you there, and I'm going to wish you very good luck, and I'm going to ask you not to miss this opportunity to make a real difference. Thank you for your time.